Hello, everyone. My name is Sarah Hanks, and I am a Maryville University Doctor of Nursing Practice scholar and student. Today, I will be presenting my DNP project, which focused on improving patient outcomes by reducing burnout in mental health professionals through the implementation of stress-reducing interventions. My DNP committee included my DNP chair, which was Dr. Gordon West, my second reader, which was Dr. Maria Snell, and my community member, which was Dr. Heather Strange. The purpose of this scholarly project was to improve patient care by reducing burnout occurrence in mental health professionals. The overall primary aim of this project was to focus on improving the rate of burnout in mental health professionals by implementing stress-reducing interventions. These stress-reducing interventions were implemented over the course of 8 weeks. The secondary aim was to observe if any improvements could be made in burnout, and in correlation also improvements in patient outcomes. The patient outcomes that this project focused on was the occurrence of falls, the occurrence of violent restraints, and the average length of stay on the unit where the project was implemented. So as background, burnout is a condition that often occurs due to a response to continuous exposure of stress, emotional exhaustion, and interpersonal conflict within the workforce. Burnout can, of course, occur outside of the workforce, but it is often experienced due to factors that are in place in different areas of the workforce. The burnout can contribute to higher turnover rates, which increases the levels of staff exhaustion, which can impact the staff's overall health, which can increase sick days, and also this can cause interdisciplinary team conflict. Persistent exposure to burnout can lead to impaired patient care, which can ultimately lead to impaired patient outcomes, more so looking at those negative patient outcomes with this project focusing on the restraints, falls, and length of stay on the unit. Literature review of this project included looking at what burnout is. So burnout is described as the phenomena of personal emotional exhaustion, depersonalization, and diminished personal accomplishment. So healthcare professionals are at a higher risk for burnout. They often experience negative changes in physical and mental health related to the burnout. Because of this, a patient's physical, psychological, emotional, and or mental well-being can be negatively impacted when cared for by a healthcare professional who is experiencing burnout due to their diminished overall well-being. It is important to note that impaired patient safety is a leading cause of disability or death across the country. Healthcare professionals who work in the field of mental health are often at higher risk for developing burnout. This is often related to the repeated exposure to trauma, often with caring for aggressive or high acuity patients, or through providing care for patients who are experiencing traumatic situations. This is a very vulnerable population to work with and can often wear on the healthcare professional, speaking from personal experience. But since burnout occurrence is increasingly prevalent in this community, it is important to identify the potential interventions that can potentially change this situation or reduce the negative outcomes that may occur due to it. Looking at changing the factors that may be contributing to burnout, I decided to focus on Kurt Lewin's change model as my theoretical framework for this project. Kurt Lewin's change model focuses on 3 different phases, and these phases help to drive and balance outside forces. The outside forces are factors that push individuals toward or away from the identified change. So the driving force is towards the change and the restraining force is away from the change. The 3 phases include the first phase, which is unfreezing. It focuses on the need to unfreeze the identified circumstances and support any driving forces that may guide the individual toward the needed change, as well as reduce any restraining forces that may be limiting the changed behaviors. For the second phase, it is moving and changing, and this consists of both the driving and restraining forces reaching a new balance. And lastly, the third and final stage or phase is refreezing, and this is the act of maintaining the new sustained change. For this DMP project, it is considered a quality improvement project, and it focused on decreasing occurrences of burnout in mental health professionals who work on an inpatient psychiatric unit who provide care for adult patients, and it is located within the designated hospital. To measure levels of burnout in the mental health professionals, a pre-post survey was utilized, and this pre-post survey did collect information to measure the possibility of burnout pre and post implementation of interventions. The tool that was used was the Oldenburg Burnout Inventory, or the OLBI, or you may hear it as the OLB. The design, once again, was that pre-post survey, and participants agreed to fill out the pre-post survey as part of their requirements of participation. The total number of participants who initially agreed to participate in the study was 25. However, the total number of participants that actually completed all requirements for the study, so that includes signing informed consent, completing the pre and post surveys, and actually implementing the stress-reducing interventions, the total number of those participants was 18. Participants were required to answer a short questionnaire to ensure that they met the criteria for participation. Prior to the implementation of the project, they were also required to read, understand, and sign an informed consent prior to participation. Focusing on that OB tool, it consists of a 16-question survey that evaluates the possibility of burnout occurrence, and it focuses on emotional and physical exhaustion, as well as professional and personal disengagement. So each question is rated 1 to 4, with 1 being strongly agree and 4 being strongly disagree. So once the participant answers all questions, which each question is that 1 to 4, the total is added, and the score can be anywhere from 16 to 64, with the higher the score, meaning the higher risk of burnout. And this is what the OB or OLBI tool looks like. You can see that there's 16 questions here, and this is how they're rated. Some of these questions, you can see that they are actually a reversed question, which means I had to go in and pretty much flip the score of the question and then total the number, and had to do this for each pre and post survey that was completed. Out of the 25 participants who originally consented to participate within the project, only 18 completed all requirements. However, because the patients use a random numerical identifier, there was no way for me to distinguish between the 25 who originally signed up and the 18 who completed all requirements as far as when I was analyzing the descriptive statistics for this project. So these percentages are based on the original 25 participants that agreed to participate. So 76% of the participants were identified as female, whereas 24 identified as male. 60% identified as Caucasian, 32% identified as African American, 4% identified as Asian, and 4% identified as African. As far as the job classes of these participants, 68% of them identified as registered nurses or RNs, 24% identified as mental health technicians or MHTs, and 8% identified as licensed practical nurses or LPNs. And these are the pie graphs that display these statistics. You can see majority female, majority registered nurses, majority Caucasian, and majority here registered nurses. For data analysis, the original goal when I was preparing to analyze the burnout data, the goal was to use a paired t-test, both pre and post survey. However, with running a paired t-test, certain assumptions have to be met, and that did not happen with this data. A violation of normality occurred, which meant that the t-test could not be completed. So instead, a Wilcoxon's signed rank test was completed to compare the pre and post intervention data, and this resulted in a p-value of being less than 0.05, which shows a statistically significant difference, and the actual p-value of the data was less than 0.001. Here you can see to the left that you can see that p-value of less than 0.001, and to the right you can see pre and post survey results. The blue you can see represents the pre-survey results, whereas the orange are the post-survey, and the green at the bottom of the graph is actually the differences. You can see the majority of the participants here reported a reduction of burnout scores, with there being a couple outliers of increasing scores. The majority, you can see at least reduced anywhere from 2 to 6 points, for some being actually the most 10 in reduction of points. And then here we are looking at the actual patient-specific outcomes. You can see here at the beginning of intervention implementation, there was a high number of restraint occurrences and high number of the actual hours of restraints. And through the intervention implementation period, you can see that there was a reduction of restraint use, and then the post survey period, you can see that this was actually maintained. And then you can also here see with the average length of stay that there was a gradual reduction seen over the course of the project. And then as far as the number of falls, you can see here in April, right before the intervention implementation, that there was a significantly high number of falls that occurred on the unit, and we can see a gradual decrease in falls with an outlier being in August. There could be several reasons of why this outlier occurred. I do not have the data to identify what contributed to this increase in falls for the month of August. As far as limitations for this project, one identified limitation was bias. So personal and research bias can often lead to skewed results and can negatively impact the implementation of a project. So it was important for me as the scholar to separate my own personal experience from the participants' experience. And it was also important for the participants to create their own unique numerical identifier to reduce that research bias. As far as population size, another limitation identified for this project, originally the goal was to have 40 to 50 participants in the project. There was a potential of 50 participants available, but only 25 team members actually agreed to participate. And as I mentioned earlier, only 18 actually completed all requirements to participate within the study, which included that they had to sign an informed consent, complete the pre and post survey, and implement the interventions over the course of 8 weeks. Small population sizes can potentially reduce generalizability and increase the chance of sampling errors, which impact the data overall. Adherence was another limitation identified for this project. The post-survey questionnaire contained a question asking if the participant completed all project requirements, which all of the participants did answer yes to. However, there was no way for the scholar to actually verify if that adherence was actually maintained. One way to mitigate some of these limitations identified so far would have been to increase the frequency of interactions between me, the principal investigator, and the potential participants prior to and during the implementation of this project. I did send several emails throughout the project, but there could have been more face-to-face interaction, and of course I could have increased the frequency of the emails. As far as generalizability for this project, it was identified as a limitation. Even though there is a great potential for replicability with this project, especially in similar settings, so other behavioral health inpatient or outpatient facilities, replicating this project in other fields or settings or with different requirements may produce varied results, which reduces the generalizability of the study. So while this project did occur on a much smaller scale, it is a topic of major importance. We see that burnout is widely experienced by various professionals in and out of healthcare, and these rates are occurring at higher percentages than ever before. And so being able to identify and either prevent or reduce burnout as early as possible improves the possibility of burnout occurring or the negative effects of burnout impacting the individual more significantly, which ultimately reduces impaired patient care and negative patient care outcomes. As evidenced by the post-survey results that occurred within this project, many of the participants within the study benefited from an overall reduction of stress, which was achieved by implementing the stress-reducing interventions. By reducing stress, this potentially improved the possibility of developing physical and mental comorbidities or reduce the severity of illness if such comorbidities already existed. And to identify causal mechanisms of stress-reducing interventions, they not only reduced burnout scores during the project, but helped to maintain an improvement overall after the project was completed. These mechanisms help to maintain an improvement of physical and or mental health of the participant. For implications for practice, applying these findings to other fields of study and practice may benefit other healthcare professionals by reducing the stress, preventing or reducing burnout, and improving negative patient outcomes. It is important to note that burnout does occur throughout all of the healthcare fields and settings, and that there are other patient-specific outcomes that should be observed to see if they are being negatively impacted by burnout. By implementing and replicating these results in other areas, not only are patients and the healthcare professionals benefited, but the healthcare organizations and healthcare systems are as well. So by improving of course, patient care and safety, this will also improve patient satisfaction scores and reduce the burden of healthcare costs overall on the organizations and healthcare systems. And because this occurs, organizations will, of course, want to continue this benefit, especially from the reduced cost and improved patient satisfaction. and this potentially will help to explore other areas of concern that may be contributing to burnout and negative patient outcomes. So these changes can contribute and maintain a more positive cycle of improved patient care, staff satisfaction and retention, and organizational support and benefit. As for my conclusion of this project, the data collected and analyzed from this study proves that there is a correlation between the phenomena and that further evaluation is needed. So replicating this project on a larger scale and in different fields and settings will hopefully provide similar results, and by providing these similar results, a demand for policy reform and change can be made and implemented. And the next couple of slides are my references for this project. I want to thank you for taking the time to watch my presentation. I hope you were able to learn something today, and I hope you have a wonderful day. Bye-bye.